Alafia Espresso Talk Today community and Aquaba to the Espresso Talk Today show. Welcome to the Espresso Talk Today show. I'm Amma Robin, host of this great and groundbreaking podcast show. If you are just joining Espresso Talk Today, then I wish you an especially happy and hearty Aquaba or welcome to the show and to the Espresso Talk Today community. Our community of amiable intellectuals welcomes everyone. We discuss everything on this Black Empowerment podcast show, from the happy and uplifting to the uncommon and the uncomfortable. Nothing is off the table here. Asante sana for joining our Black Empowerment podcast show. Remember, Black health is Black empowerment. You might have noticed that I greeted you with the saying Alafia. Alafia is a word in the Yoruba language meaning good health and peace. Today's show focuses on Black health and the racial health disparities in the American healthcare system. We're going to be asking lots of questions, but we may focus on addressing questions like, do culture and ethnicity play a role in one's health outcome? Should doctors consider culture and ethnicity when examining and treating patients? Do different cultures and ethnicities display different health problems and require different treatment approaches? We're going to discuss all of these questions and more. Spoiler alert, yes to all of those questions, but that's just the beginning. The Espresso Talk Today team is meeting with Dr. Gregory Hall, who is a general practitioner, everyone's favorite kind of doctor. He's a researcher, a scientist, and an author. I'll tell you more about him in just a minute. And yes, there's a lot more. Asante sana to Dr. Gregory Hall for meeting with the Espresso Talk Today team for this show. Mel will arrive in just a minute. Then we'll get started. While we wait for my esteemed ETT team member, let me just tell you a little bit about Dr. Gregory Hall. Dr. Hall is a primary care physician practicing in Cleveland, Ohio for over 30 years. He's the author, remember I said he's an author, he's the author of the book Patient-Centered Clinical Care for African Americans, a concise, evidence-based guide to important differences and better outcomes. The book, written for medical providers and the first of its kind, gives best practices in the clinical care for African Americans. Now, I've read Dr. Hall's book, and I can tell you that I learned so much. I'm not a healthcare professional, but I found this book to be very readable and so informative. I really just couldn't put it down. We're going to discuss it during the show, so stay tuned. Dr. Hall has a dual appointment on the teaching faculty at Northeast Ohio Medical University College of Medicine as Associate Professor of both Internal Medicine and Integrative Medical Sciences. Dr. Gregory Hall has lectured on various topics ranging from hypertension to permanent body art, that's right, about tattoos, to health disparities as well. But his latest passion is to improve the general public's knowledge about the important differences and the needs in the healthcare of African Americans. You know, like old-time doctors, he sees patients in his office in Richmond Heights and at 4 area nursing homes. Yes, he's still practicing. I can't believe how lucky we are to have him on the show today. Dr. Hall is also the director of the National Institute for African American Health, whose mission is to improve the health of African Americans by providing a trusted source of health information tailored to the needs of our community. It also aims to increase the number of Black physicians available across all medical specialties. We're going to talk a lot about this. But to prepare for this show, the ETT team did a lot of research on Dr. Hall, and in addition to his professional achievements and background and experience, Dr. Hall has been described as kind, caring, comical, and extremely competent. His patients say that you will immediately feel at ease with Dr. Hall. Mel and I absolutely agree. I think that you will too after this podcast show. I just want to close with a quote by Dr. Hall. He says, "There are important differences in the medical care of African Americans that can impact health and recovery. To ignore them is simply unacceptable." There's so much more that I could say about Dr. Hall's background and experience, but Mel just arrived, so we can get this show started. I'm going to stop here and just let the good doctor speak for himself. Let's get it started. Hey, Mel.
Hi, Robin. How are you?
I'm doing great. I'm doing great. How are you today?
I am doing fantastic.
Oh, really? Because I'm
Oh
feeling a
yeah.
little bit of a cold. Is that right?
Yeah, but I'm going to take the approach that, it's just temporary.
I like that. Yep. And it'll move on.
Of
Well,
course.
as you see, I'm having an espresso with today's guest, and I want you to meet Dr. Gregory Hall.
Dr. Hall, it is so wonderful to meet you.
It's great to meet you as well.
Dr. Hall is a specialist in internal medicine, a GP, a general practitioner, everybody's favorite doctor. And I know, and I'm meeting with Dr. Hall today, but don't worry, I feel fine. Not, not a consultation, at least not that kind. Look, Dr. Hall is here today to talk with me about racial disparities in healthcare, and particularly how they affect Black Americans and the important differences in treatment and outcomes in certain diseases. So, we're going to also discuss what's called patient centered care. I haven't heard that term before, so that really piqued my interest. And I see Dr. Hall's written a book called Patient Centered Clinical Care for African Americans. So that also throws in another aspect of it. It's patient centered, but culturally competent clinical care. And, I realize as I'm saying this that we are probably going to need a double espresso to discuss all of this.
Well,
So,
in view of my cold, I'm on mint tea.
okay, a double mint is fine too. And
Okay.
so, anyway, I'm happy that he's joining us today for an espresso. I'm happy that you're joining us today for a mint tea. And Dr. Hall, Asante Sana for joining us today.
Well, thank you. I appreciate it. It's great to be here. I'm happy to talk to you and learn from you. And it's just a great opportunity.
Well, I have read your incredible book and I learned so much. And, it's one of those books where I end up just highlighting everything. Then I said, Robin, that's not going to be as helpful, but there's so much great information and I can't wait to talk with you about that. Um, But one thing I've been doing, because I am a big reader, and this is the week of Dr. King's, birthday, and this is his holiday. I've been reading a lot by Martin Luther King, and I came across a quote. He's such a quotable person that I thought that you might be interested in, and I want to present that to you to get us going. And
Sure.
it says here, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I get three things from that. You know what? Who cares what I get? What do you think about that?
Well, I probably first heard that maybe 20 years ago, maybe 20, a little bit more. When I was appointed to the Ohio Commission on Minority Health, right? It's a Ohio Commission. It looks at health disparities for all minorities, right? And they needed someone from Cleveland because they're Columbus and Young. They had sort of representatives. They needed someone from Cleveland, so some kind of way they chose me. And I didn't know anything about health disparities. I didn't know anything about, I just thought we were all the same and we all got treated the same and doctors treated all patients the same. I was basically really ignorant, right? uh, but I didn't know it. And so when people don't know these things, I try to say, I didn't know either. And so the executive director was Cheryl Boyce, who was just she was just a really just a wonderful person. And she's passed but she mentioned that quote, and I was like, wow, even Martin Luther King knew about health disparities. I mean, and it's so true, because I didn't think people treated people. I didn't know anything about the Tuskegee, syphilis study. I just was just a void of stuff, and having been in medical school and residency, none of that stuff was discussed.
Wow.
It wasn't even touched on. It was, we were all in the clouds, what I mean, anatomy and physiology and things like that. So, but of course it's true. I mean, it's true. It's inhumane. It's shocking. It's shocking kind of all around. There are some really good, honest, dedicated doctors who don't know about all this stuff. You know what I mean? And so when they find out what, you're shocked, right? And it's like, could treat another person like that? You could experiment on someone. You could neglect someone like this that comes to you for help. And the truth is, yes. And a lot of that time in that history has been suppressed, like so many other histories. You know what I mean? In terms of, you turn the TV on back in the 60s and 70s, you didn't hear anything about doctors treating, other doctors poorly, right? I was born at a Black hospital in Cleveland called Forest City Hospital. And so when I speak in Cleveland, I say, I was born in Forest City Hospital. They're looking at me, Mount Sinai, Cleveland Clinic, University Hospital. I've never heard of Forest City. Well, because my mother had a Black OB. And black doctors were not allowed in the mainstream hospitals. And that was not each hospital's decision. That was a national thing. The American Medical Association supported the segregation of Hispanic, Latino, and Black physicians not being allowed, in the mainstream because of, either one rule or another. So, and I know I've sort of gone off on tangents, but so people but doctors, a lot of doctors don't know this. A lot of patients don't know this, and some people are innocently ignorant of it. You know what I'm saying? And then other people are more deliberate about kind of sticking their head in the sand.
I mean, like, in medical school, these kinds of things weren't discussed. I mean, there wasn't like a history of medicine. I mean, I understand there were some things with, Sims. I don't even want to call him Dr. Sims, but
yeah, there was a wonderful history of medicine.
oh.
it just that didn't include African Americans. You know what I mean? We learned, oh man, we learned about the guy that developed the microscope and the stethoscope, and like you say, the father of gynecology and all that stuff. But our history was, had holes in it, right? So it was, so it wasn't the frank truth was not there. No one talked about the fact that Black doctors weren't allowed. They just weren't allowed. You know what I'm saying? It wasn't, they didn't go on TV and talk about that. You know what I'm saying? It was just understood.
Now, for the shocking and inhumane part of that, was that back then, or is that still happening now? So,
well, it's still happening now. I mean, there's some shocking things. There's some inhumane things. I think it's much less, but the damage that was done, throughout the last 500 years, has impacted the outcome. Now there are a ton of things in place now to prevent, doctors abusing patients, what I mean, things of that nature. And we have rights, and there are lawyers on TV that want to make us pay, right? if we do something wrong. And so that tends to keep people in line, right? I mean, and so there are, HIPAA laws that keep people from sharing information about someone. And there's all sorts of ethical committees that prevent experimentation without, full disclosure, or surgery without full disclosure and consent. So those things are in place really to protect everyone, and they also protect African Americans. And so, but now, African American patients, many of my patients don't want to go to the doctor. They don't want to. If something's wrong with them, I don't want to know about it, right? Because they've had years of bad experiences with doctors and hospitals and things of that nature. And now that things are better, people are still incredibly hesitant. So some of it, like, I don't blame. There were people that said, if you don't get the coronavirus vaccine, I'm not going to see you. There were, doctors that kind of felt that way. Why? I don't want to be exposed to a patient that doesn't even want to use, get a vaccine. But I never said that because I'd lose half my patients. Number one, I mean, and I understood why they felt like, they wanted to wait. You know what I'm saying? And so I think what this has shown is that time has shown that it was okay, and this is a way to sort of build trust. But I think it's we don't necessarily take advantage of everything. So, like, I'm the president of our county board of health, and so I was deliberate about making sure that African Americans in Cuyahoga County had first access to the vaccine. And and that if we did something in the suburbs, we also did something in the city, right? And so when we did stuff in the city early on, there was people driving from the suburbs. We got Mercedes Benz and Lincolns and whatnot lined up on St. Clair, what I mean, to get the vaccines in the city, and then the black people peering out the windows. I ain't getting that shot. What I mean? So, why are they coming here? They ain't been here before. But they weren't maybe not aware they had a president of the board of health pushing that.
Right.
A third of our population is African American. But I had patients say, why now? Why are y'all pushing? You got commercials, you got this. Why are y'all pushing this? It seems like you're pushing it too hard. But it was like, if we don't do it, then we're neglecting our population, right? And if we do it, they're like, well, why are you doing it? So but I get it, but all that suspicion and whatnot can lead to disproportionate outcomes as it relates to COVID and pneumonia and complications of it and all that. So, that's just an example of how we still can have these shocking outcomes, and there's not one simple, easy, just trying to make sure there was access to the cutting edge vaccines had a paradoxical effect in some people, thinking that you're pushing it a little too hard, and I don't, maybe you're trying to inject things in me. Yeah. And so that it opened my eyes in a number of different ways.
Mm-hmm.
Well, one of the things I also think of, experimentation, that's just, shocking and inhumane, absolutely. But I also think that when I look at some of the data that I watched one of your videos, and you were discussing the data of the increased risk for Black Americans of, hypertension and heart disease and obesity and cancer, and that, we're at the, we have, the appearance of that in our community. It shows up a lot, and then we have the worst outcomes. That to me is shocking and inhumane. Is that considered acceptable?
No, it's not. And what we've done for a long time was talk about it, and say, what is the medical establishment going to do about that? And many times it got attached, which is one of my pet peeves, it got attached to poverty. You know what I mean? That, and insurance access. If all Black people had insurance, and if all Black people weren't poor, then our health outcomes would be better. But again, the data does not support that. So me as a doctor, I tell people I'm certainly an upper class African American. I'm probably an upper middle class compared to the white population. You know what I mean? But I'm for sure an upper class African. I'm not Oprah, but I'm upper class, right? but my risk for prostate cancer, dying for prostate cancer, is worse than the poorest white person. You know what I mean? So that's the thing. My risk for dying from hypertension, for a stroke, is worse than the poorest white person. The poorest Asian American. So it's and they there's data again in that book that does the quartiles. It shows the highest income quartile, which is like 80,000. Which of course I'm above, right? But those people still have worse outcomes than the people who are below poverty level in other racial ethnic groups. And there's a lot to that, right? Some of it's diet. I grew up Black. I'll admit it. I like chitlins. I like pig feet. I don't eat them often because I know it's bad.
That's it.
I might eat them every 2 years, but I like it, because my mother made it, and it makes me think about her. You know what I'm saying? And
Yeah.
but so it's sort of like comfort food. My father says, stick to your ribs. We have those cultural things that we think about and we cling to. Now my mother stopped with salt when it came out. The early '70s, that salt was bad for you. She stopped salt big time. And we used to, when we got a plate put in front of us, the first thing we did was grab the salt shaker and salt everything on the plate. That was the first thing, without tasting it. We did that. And when my mother found that out about salt, she removed salt from the table, and so she says, I've cooked it. You all have to eat it. You know what I'm saying?
Right.
You can't put salt. You can put some hot sauce on it, but you can't salt it. And so now we adjusted so that there's much less salt. You know what I'm saying? So
Right.
there's issues in terms of what we do as a culture that may drive increased health outcomes. Salting our foods, fried foods, fast foods, pork. Those things. Not enough vegetables, not enough fresh fruit. Too much processed food. All those things drive up health outcomes. So a lot of what we do drives poor outcomes. But aside from that, when we present with a stroke, in many places we're not getting the same care, and so that's bias. That's race driven. We're less apt to get a referral to physical therapy. We're less apt to get, I could just go on. You see it in the book,
Yep.
all the things that we're less apt to do, and that's provider driven. And that's why when I try to speak to doctors and nurse practitioners and whatnot and say, we're not just sitting back and watching this happen. We're doing some of it. Now, and so whatever part we're doing, we need to work on. Whatever part, the African Americans are doing, they need to work on, walking and exercise. And, you're not eating something right, at least know it's not good for you. You know what I mean? I know this isn't good for me, so I'm only going to eat this once every 2 years. You know what I'm saying? But at least know you got to eat a salad. Have I had a salad today? Know whether you've had a salad. Know you're supposed to have had one, right? And so health literacy drives a lot of poor outcomes. So you've got people who may make good money, but they're still health illiterate, right? So they're drinking Kool-Aid with their dinner. They're drinking a pop, Coke or Pepsi with meals. And so, and African Americans disproportionately drink sugary, sweetened beverages. But if you look around and people of other races or ethnicities that live longer, what do they have? They're having water with lemon, or just water, or and just look at it and you'll see. And we're asking for, where's the Sprite, 7-Up? You know what I mean? That's what we drink with meals, right? So all that's driving obesity and whatnot. So we all have a part to play in these shocking disparities, but everyone needs to sort of realize the part that they play, including doctors.
Yeah, but I also do. I mean, people, my son brings this up a lot too, these kinds of things. And I always say, but I see, white people going into McDonald's and, supersizing, and all of that. And it doesn't that make it different for them too. I see white people smoking
Oh
and
my God,
drinking.
yes.
Yeah, maybe
Well,
not eat chitlins, but
yeah.
pork butt. So
Well, it does. Well, it does. I accepted a job at University Hospital as a medical director of the Cutler Center for Men, which talks about white men as well. And so as an African American male, my life expectancy is 71 now. Now I'm 61 right now, so that gives me 10 years, right? So African American people, you guys are 78, right? And so your life expectancy is 78, mine's 71. So white males is also about 77. So a Asian American woman is 87.
Oh, wow.
And an Asian American male is like 85.
Wow.
So white men don't live as long as Asian American men or even Hispanic Latino men, which is in the low 80s. So there's significant disparities in health in the negative factor as it relates to white men. And so what we spend a lot of time comparing ourselves to whites overall, because they're in the vast majority of the population, right? And we'll say we live, 5 years less than whites, you know what I mean, or this or that. But they're not the gold standard. Asian Americans are the gold standard. Hispanic Latino Americans all live longer than whites.
Wow.
And then there's whites, then there's African Americans. So again, when I was appointed to the Commission on Minority Health, I thought minorities had bad outcomes. The majority of white people had the best outcomes, but that's not what the data shows. Life expectancy for Asian Americans and Hispanic Latino Americans are better than white Americans. Wow. And then we're worse. And then Native American and Alaskan natives are the absolute worst. So they're at the but they don't live in Northeast Ohio. So, so it's not something I have to address.
So when we go to the doctor and for advice, the times that we do go, and the doctor gives us information and advice, how do we know that we're getting the right information? How do we know that we should follow that advice?
Well, because I think initially there's selfish reasons. So all of the doctors' outcomes, we were assigned NPI numbers. I don't know if you ever heard of NPI numbers, but doctors, all practitioners, doctors, nurse practitioners, physician assistants, we all have an NPI number. And everything is tracked, everything we do is tracked by that number, by that NPI number. So people know this, I don't know who they are, but there are people that know how long my patients live. What's my success with having my patients get mammograms every year? What's my success with getting colonoscopies every year? And so there's grades that the insurance companies have access to that know what the provider is doing. So I tell patients that are going to have surgery, if the surgeon wants to do surgery on you, he's fairly certain you're going to live and be successful, because it's going to make his data look bad if you don't. It's just like that's just pure and simple. It'll follow them, and they can't have a surgeon every time they do surgery. People don't make it, right? And so I used to run those reports when I worked at Cleveland Clinic before I went to medical school. The success rate for open heart surgeries, for example, and they see that. And if there's a surgeon who's lagging behind, you're a stepchild until you can get that fixed. So when doctors in a selfish way are trying to make their data look good whenever they're treating a patient, because that's, it's about how they reflect, how many of their patients have uncontrolled, when we are in electronic medical records, it's tracking what's the blood pressure, my patient's blood pressure, what's my patient's cholesterol, what's my patient, when was the last time they had this, that, and that. All that's collected by my employer, University Hospital, to make sure that I'm giving the best care, because that's what they present. They want to be able to give the best care. So these things are in place really to improve quality outcomes, because that saves money for the insurance companies, right? The insurance companies make money by saving money, by not spending money, what I mean, on things. And so a healthy patient is cheaper than a sick patient, So it's in the doctor's best interest to be in your best interest. Aside from that, you still should feel like the patient's on your side. I mean, they need to communicate with you. They need to talk to you. They need to listen to you. That's important as well, to find out what are your likes, what are your preferences, so that I can prescribe something that's in your favor.
Well, there is an issue of, this was, I thought, very interesting in the book, about patient trust. And I think a lot of that, particularly with African Americans, and I know I was kind of raised to go into the office of certain professionals and be skeptical, teachers, definitely doctors, and was kind of anybody that wasn't necessarily in my, circle. So certainly with doctors, there is a level of trust that I just don't have.
Right. You're not alone. You're not alone. A lot, 45% of African Americans don't trust healthcare providers, hospitals, stuff like that. So that's almost half. Wow. And so it's and they come in without that trust. So, but if you think you have someone who comes from India, East India, right, comes here, they revere and completely trust doctors. whatever the doctor says, complete, total trust. Yes, doctor. You know what I'm saying? So it's cultural in a sense, right? So the Halls, my father's side of the family, we had doctors and lawyers and whatnot. My mother's side of the family, not so much. And so I told my grandmother I was going to be, on my mother's side, I was going to be a doctor. She said, right? Like I'm gonna be a child molester. She was not impressed, not impressed at all. And I'm like, oh, this is like, I'm the only person with a grandmother who doesn't want her grandson to be a doctor, right? And she just didn't like doctors. That's what it was. So she didn't want me to go into a profession that she didn't like. She didn't like the people. And she told me about having a tonsillitis and going to the doctor, a white doctor, and then he got some forceps, reached in there and ripped out her tonsil.
Oh.
And then held her down, reached in and ripped out the other one. And so every time she would see somebody on TV getting ice cream, having their tonsil out, we were little, so-and-so had their tonsils out and they're eating ice cream in the hospital. She's like, that dirty dog didn't give me any of that. He literally ripped it out the back of my throat. Isn't that crazy? And so that experience for her as a child influenced how she looked at the doctors, at the profession, and these people are not in my corner. And then when she would see how other people got treated when they presented with a similar presentation, that just infuriated her all over again. You see what I'm saying?
I do.
And so that doctor really ruined a lot of people. You know what I'm saying? Because he couldn't be bothered putting a little black girl in the hospital and giving her ice cream and all that. He knew her tonsils needed to come out, so he just ripped them out. It's terrible. Mm-hmm. But that was not unusual, right? That's what they did. Remember the guy that's a father of gynecology did all those experiments on unanesthetized black slave girls. Imagine that. I mean, just surgery without anesthesia, and so that colors, how people look at that. And then when they suppress the history, like it's been, when it's suppressed and the next generation don't know, but they feel it. Grandma didn't. I love grandma, and grandma doesn't like doctors, so I don't like. Or what they say, you going to the doctor? I mean, these things matter.
Well, that raises the issue of you had in your book about pain, and it's I understand it. African Americans have a lower threshold for pain than Caucasians, white, European types. So, can you explain that? And what's the?
Yeah, what they do is they measure. There's different types of pain. I'm not a pain specialist, but there's different types of pain. There's a sharp pain. There's a burning pain. There's a couple other types of pain, and so they had a way of giving the same amount of stimulation to African Americans, to whites, to Asians, in order to determine what their perception of was, right? And what did you perceive? How would you rate that? Mm-hmm. And they just found when they did that African Americans tend to feel more pain. They tend to rate it as an equal amount of whatever it is they were doing. African Americans tend to rate that as more severe than whites in the study. And so that goes against what providers' perceptions is, African Americans can take pain. We've been abusing them for 2,000 years, right? They can take pain, So it's like the skin is thicker and all these, sort of hunches that were not based on anything. And so, so the bias plays a big part. And so if you look on TV and the drug dealers and the drug users are all African Americans, and you see a young African American boy with, hair all over his head, he's probably a drug user. So I don't want to give him any Percocet to make him go be more drugged out. You know what I mean? Then my bias is telling me he might be, right? So you're less able to providers feel less apt to give someone some Percocet who might abuse it or who might be selling it. And then an equal looking white person who come in clean cut, he's less apt to be selling it and whatnot, because I don't see that on TV, right?
Mm-hmm.
You know, and so that those biases impact greatly who gets pain medicine. And then, despite the opioid epidemic, which is opioids is a problem, and I know people who have died, African Americans who have died, African Americans have less tendency to get addicted to opioids. That data is out there too. So in reality, we're less apt to abuse it. We're less apt to be addicted to it compared to whites, right? But then we're less apt to get it. So it's just like the opposite. It's the opposite of what people would think. So if you're giving an African American some opioids, they're less apt to get addicted to it. Than an equal age, sex, white person. So, but providers think the opposite. They think they're more apt to get addicted to it, and just for whatever reason, that's just what the data shows.
So if you go into a doctor's office and you present with pain for some reason, it's not like you or injured or anything like that, or cut or something like that, you're less likely to get a prescription for that. Is that what you're saying?
Well, yeah, the data shows that African Americans are less likely to get their pain treated than comparable whites. That data is there, and it's been shown over and over again. But now with the opioid epidemic, everyone's less apt to get an opioid. Like I used to have people that would come monthly to get, for their chronic pain or chronic pancreatitis or whatever. And I can prescribe. I don't do that. I don't have anyone come in my office on a monthly basis. I have to refer them to pain management, at least here in Ohio, because of that, because of the laws. If someone's being treated for chronic pain, I have to send them to pain management. If you fall down the last 3 stairs and going to the basement or something and injure your knee, I can give you 3 or 4 days worth of opioids, but I can't give you a month's supply. So I can treat you for an acute event. I just hurt myself. It's severe. I can give you some pain medicine for 3, 4 days, but I can't give you a month's supply. And 15 years ago, I probably had 20 people that were coming every month getting, 90 or 100, Percocet every month. And they weren't abusing it. They were just treating their pain. But, there were people elsewhere who were getting hooked on it. I guess who were doing heroin. I grew up in the inner city, in Cleveland, and I didn't know a lot of heroin addicts. You know what I mean? I knew some marijuana smokers. They were a ton of them, but no heroin addicts. You know what I mean? Some crackheads. I knew crackheads, but so it's like when they say, I'm giving someone Percocet and all of a sudden they're shooting heroin. That's not as prevalent in the African American community. And the data shows that as well, right? But there are people who now, fentanyl and up, now there's people hooked on it, and African Americans are dying from that, unfortunately. But they're not dying at the rate of the majority population. And so that's why some people are saying, now being addicted to opioids it's a medical problem, right? Now we can't put them in jail for that. Like when you did crack, Black people doing crack, you could put in prison for that. You know what I'm saying, right? But now that it's really more prevalent in the majority populations, they're pushing for more treatment, medical treatment, addiction services, redirecting people. Don't arrest them for that. So it's really a different approach, and I think it's because of the population that's been impacted by it.
Yeah, I mean, it's the right approach. I mean, I don't believe in criminalizing addiction, and it never should have been. It should be treated as a medical issue. But it's just too bad that it has to wait until it gets more prevalent in the white population before that happens. But I still wonder, about what's happening in the doctor's office. And I saw in your book you mentioned patient satisfaction, patient adherence improves health outcomes, and that patient culture actually was part of that too. Could you discuss some of that?
Yeah, well, I mean, in a fundamental way, when Black people go to Black doctors, they do better. They have, and that's from birth. Black women that go to OBs have better outcomes. Go to Black OBs, they have a lower infant mortality rate. The patients do better. to all the way through. And so Black people are better off in the hands of overall population wide. The data has shown that they're better off in the hands of a Black doctor, but there's not enough Black doctors to go around. There's not enough. There's 4% of doctors, 4 to 5% of doctors are African American compared to 13% of the population. So that's a disparity right there, right? That 4% can't take care of that 14%, and certainly across specialties. African Americans tend to go into the primary care specialties, and we tend to care for African Americans. That's just how it works out. And that's probably where we can get a job. You know what I mean?
Yeah.
Be frank about it, right? And so that data is just there broadly that people do better. Now, in terms of all the decision makings and biases, and they're I have patients who love their white doctors or love their East Indian doctors. They love them. So it's not, you can't paint a whole population, and get great care from them. But when you look at the broad overall, then you see something that's different, right? And so that's what we have to, as me being a doctor and a scientist and a researcher, I everything I do is based on what did the research show? What does the research say about, in terms of, because that's what majority population scientists will say, what does the research show? You feel like this, but like, for example, like they'll say that in terms of biased decisions, that a lot of doctors may feel biased. They feel that white patients are more compliant, more adherent to medications, which is true. They follow through with their orders better, which is true, right? But that when they look at what the orders are given, the providers are all doing the right thing. It's just that the African American is not really feeling that doctor. So I'm not going to get this prescription filled. You know what I mean? So so then we see that everyone's got a prescription for amlodipine for their blood pressure, but the African Americans tended to not go to the pharmacy and get it at a much lower rate than the white Americans or the Asian Americans or the Hispanic Latino Americans, right? And so so they're getting the orders, but they're not going through because they're not feeling the person who gave them the orders.
Mm-hmm.
And it's happened with me. I've given the African Americans orders to, a prescription for something for their blood pressure, and come back in 3 months, and they come back 3 months later. I never got that thing. I wasn't sure. I'm like, I'm not trying to hurt you. I'm just trying to make sure you live. So it's not even, I have trouble. Patients have trouble trusting me. I make sure I'm in their corner. I might say, which I've done, let's let your blood pressure's high. Let's try amlodipine. What do you mean try? Well, why are you trying? You experimenting on me? Why don't you don't know whether it's gonna work? What is that? So I was like, well, we're not trying. We're gonna see what it's gonna do in you. I have to have that again, that extended conversation, because all that suspicion that the doctor professions have ingrained in African Americans to make us suspicious about everything we do. Why are we doing this test? Why are you putting me on medicine? Why are you trying to help me live? You haven't done that in the past. All those things go in people. And then when the patient isn't health literate, when the patient doesn't know what their blood pressure should be, what their cholesterol should be, then that makes that mystery and that suspicion even worse. So that's why I spend time talking to you, saying, patients need to know your blood pressure needs to be less than 135 over less than 85. That's what your blood pressure should be. And you should know that. And you should have a machine at home that measures your blood pressure. Don't trust your doctor to check your blood pressure. And then you tell him, I was excited. I was mad. I had to wait. I had an accident on the way here. And that's what drove my blood pressure up. No, you have high blood pressure. You know what I'm saying? You measure at home and under the best situation, it's just you and those numbers, then you can convince yourself you have hypertension, and that's associated with increased stroke, heart attack, kidney failure. Bring that down. So then if you're working with someone who's health literate, you say your blood pressure is high. Here's amlodipine. You already knew. Yeah, I looked online. I know you're probably going to put me on amlodipine because that works best in African Americans. I know what blood pressure is supposed to be. So now it's a much easier interaction between the provider and, and the patient, because the patient has increased health literacy.
Hmm.
Okay, but I still think there's a cultural aspect there too, because I mean, I think one thing you said in the book, I may be misquoting you, was that doctors, when the patients do go into, see their doctor, and there's a level of distrust, which the medical community has earned some of that distrust.
Yes.
Yeah. So, I think it's easy to blame the patient, but I think we need to really look at the responsibility all around.
No, absolutely. And yeah, now maybe I gave the wrong impression. The responsibility goes all around, right? But what frustrates me as an African American is that we wring our hands about what society is doing, what the establishment is doing, what's being done to us, and we don't do enough to what we can do, because they have not shown they're going to do us right, right?
True.
They've never shown. They've never shown that. I'm not trying to do anything. They've never shown they're going to do us right. So if we're going to get done right, who's going to drive that? We have to drive that. We have to drive that. We got to make sure there's more doctors. There's more Black doctors. We got to make sure we hold people accountable when they don't treat us right. We have to make sure we learn more about how we're supposed to be treated.
Yeah.
And that's why, sitting back and waiting for, Joe Biden to fix how he may be our best bet. You know what I'm saying? But waiting for that, not a good plan. Not a good plan. I mean, it's not a good plan. And so we our plan needs to be one of self-empowerment, self-education, have a better, stronger community, less infighting, where we more trust of at least people who deserve trust, right? And that I just think that's our approach, because if we just kind of keep complaining, we've been complaining all my life. You know what I'm saying?
Yeah, we're complaining people, yes.
And so it's time. It's now time to start doing something, which is why, I was like, I've only got so much time left according to the data, right? I got 10 years left according to the data. If that, right? And so I need to try to do something to try to move the needle on health, because that's, we complain about it and blaming other people has not moved the needle.
Okay.
Yeah, you created the National Institute for African American Health. Why did you form this institute, and what does it do?
Well, it does. It has, and thank you for asking. And it actually leads into that, because the number one thing it does is increase the number of Black doctors. We're mentoring pre-med and medical students, Black pre-med and medical students. We're linking them up with Black doctors who want to help. And so everyone who's a pre-med student, Black, or a medical student, gets linked up with a physician, so they can help them on that path, right? So they can, because everyone needs help, and so that our goal is to increase the number of Black doctors across specialties. And that can be done just by people dispelling, rumors. It's, the system is set up to put barriers. Pre-med students get weeded out, and there's barriers that you have to kind of pass, right?
Mm-hmm.
And they've been doing this for years. And so if you don't know, this class, organic chemistry, is a weeder class, right? So I tell people, I took organic chemistry in the summer. I audited organic chemistry here in Cleveland at Cleveland State. Then I went back to college in the fall and took organic chemistry for real. I was really taking it for the second time. But that's how you get a good grade in something, right? Because this is what makes pre-med students not pre-med students anymore.
Mm-hmm.
Right? So someone told me that, and so I did that, right? Because this is where the rubber meets the road, organic chemistry. So, if a mentor said, how many inner city Black kids don't have a doctor to pull them aside and say, this is where you're going to get weeded out, so you better prepare. Don't take a whole lot of crazy classes all at once. And there's guidance counselors all across the country that are giving freshman pre-med students chemistry, biology, English, and math to
Ooh.
start college, and by Halloween, they're done. I mean, they're not pre-med anymore. I mean, when in reality they say, you need to just take biology and some easy classes, biology and English, and then see how you do with that, and be very strategic about what you do and strategic about what you take in high school. So anyway, the NIA, we call it National Institute for African American Health, has 4 pillars. One is increase the number of Black doctors through mentorship and collaboration, right? The second is have an online source of trusted information. So these Black mentors of doctors from across the country are going to advance information that hopefully would be more trusted. It's not Black people don't trust the CDC or the government or the hospital. And so where do we go for trusted health information? We're hoping that NIA.org will be a place that people can kind of go to and read articles that are written by Black doctors, Black professionals, and Black PhDs, and learn, be just a resource that can be trusted, or at least have a debate. There's no one truth across a whole lot of issues, right? And so let me get the information that's for it. What's the information against it? And have a trusted course. The third is research, be a repository for research in African Americans for best practices, like what I wrote about. What should you do? When should you start getting mammograms? When should you get colonoscopies? And again, be a sort of a trusted sort of, if I'm going to be in a research trial, I'm at least in one from somebody who Black people who vetted it, making sure they're not experimenting on me. You know what I'm saying? And we're also going to educate providers in best practices in African Americans, really related to the book. And the last part is patient advocacy, where we're going to advocate on behalf of patients. And so our team of Black doctors across specialties, if you had some sort of a bad outcome at a hospital and you believe it may have been related to race or inferior care, you can have your records reviewed by a specialist, who's a general surgeon or whatever, look at it and say, you didn't receive the best care you could have, or this wasn't right. Because a lot of times when those cases occur, it's between the lawyer and their brother-in-law doctor, right? The brother-in-law doctor may be friends with the doctor who may not have done right, to the African American patient. And so it's important to have access to someone who might be able to say, this really probably wasn't right, and then be willing to be an expert witness in that case. And as a doctor, I hate malpractice. I hate all those things, but it's still we still need to make sure that the providers are providing African Americans with the best care. The other thing we do is also defend African American providers against frivolous cases. I mean, there are definitely frivolous cases brought against African American providers because, again, the lawyer's brother-in-law may not have any compunction about suing the Black doctor who he didn't go to medical school with. You know what I'm saying? And it's really not a good case, but it's presented in a way so that we can kind of defend and increase the number of Black doctors. If you're putting doctors out of business because they can't afford malpractice or they can't afford, this, that, and the other, we need as an organization to be there, a nonprofit, to help protect the African American community.
I think I misunderstood something about the advocacy program, because I'm thinking of a patient advocate, someone to go in with me to the doctor if I don't have someone else. Is that a part of it?
You know what? It really is more. It's advocating on behalf of patients, but that certainly that's very critical. But that's not something we're taking on as a nonprofit. But that is that's like doulas with women that are pregnant, and community health workers, kind of helping to interpret when they go in with the doctor and help them with that. That's a part of it, but that's not what we're doing. In terms of our patient advocacy is really at the provider level. We're advocating. We're making sure the providers do what they're supposed to do, and we're also making sure the providers are educated in best practices. So we'll be before long, we'll know as African Americans to ask, is our provider NIA certified in the clinical care of African Americans? If you've got 80% African Americans, read about them. Learn about the communication, learn about this distrust that I didn't know about as an African American. I didn't know I'm in the 55% that trusted doctors, right? My grandmother was in the 45% that didn't. We didn't know about each other, right? And so if a provider knows that, it's a totally different interaction. I've come in the exam room a million times and I haven't even met you. Where are you met? Was I late? What I haven't even met. Why are you mad at me and I haven't even met you? So now I'm a nice person. I get an attitude. What's this crazy woman mad at me? Right? She's got attitude. Now he's got an attitude. I knew he was a bad. I knew doctor. I knew I don't like. So that's like verifying, validating what they already suspected. So now we are in a dysfunctional relationship from moment one, right? Now that I know it's a thing, when I go in a room and I see that, one of the 45%, where'd you go to high school? I grew up on St. Clair. I make myself a regular, you know what I mean? I'm not the big bad doctor. I do a lot of schmoozing early on, let them know I'm a nice person, that I get what they're talking about. I know that the medical establishment has done this, that, and the other thing. And that breaks down, for the vast majority of them, it breaks down those barriers, you know what I mean? And allows us to have a functional relationship. But we would get off to a bad start in the past. I have to admit it, just because I see that attitude and then I get an attitude. Now we got two people with attitude. That's not doing anything. Yeah. But I didn't know, right? So now we educate providers about that, then they know it's better. It's better if you sit down. Like I try not to I'll cross my arms while the patient's talking. I'm not supposed to do that. Keep your arms open. I'm open to what you're saying. You see what I'm saying? But I just, my hands are cold. I'm just, crossing. But that's like, I'm not open to what you're saying if my arms are crossed. So you learn that. So in my head, when I'm listening and I want to do that, I said, no, don't do that. Sit down, make eye contact, don't type. These are things that we providers can learn, that makes the encounter so much more functional.
Mm-hmm. Yeah, I've been in appointments where the doctor is on a computer typing in whatever kinds of things he might observe or I might say, and there's no eye contact.
Yeah, they never look up from the computer. I know, and because they're trying to document everything so that when they're done, they have to spend all night doing their notes like I do now. But you can't do that at the expense of not gaining that trust that we talked about earlier, right? You have to be able to make the eye contact, nod, listen, and all that, so it doesn't look like you're not listening to them.
For the patient, is it a good idea to take somebody with you?
Mm-hmm.
Like a friend or relative or somebody, because you're the person who's ill or who may get some bad news, whatever. So you may not pick up everything that's going on.
Right, and that's best practice, and that there's research that shows that what you're saying is true as well. That when someone is given bad news, their ears almost stop listening, and they're in their head thinking, planning a funeral and doing all that. When it's really, you're getting instructions on how you can live, and so having another person with you in the room can help you remember, all the things that's going. And so you're more apt to follow through on those instructions. During COVID, we couldn't have people in the waiting room, and the room, it was just a mess. And it was, it was hard to communicate with people who I knew needed help. When you're talking about diet with someone with diabetes and the person who cooks isn't in the room, that's a waste of time. You need who's cooks at home, right? We need that person in here so we can adjust it. So yeah, it's absolutely, having someone in the room with you is really, really helpful. Almost really across the board, to be honest with you.
Can you discuss some other best practices? You mentioned a few, but I'd love.
Like I said, learning a little bit about, if you have hypertension, what your blood pressure should be, know what your cholesterol should be, know your family history. You want to know what, if your mother and father died from heart disease or heart stroke early on or something, then you're at increased risk. Nothing trumps genetics, fruit falling up under the tree, right? So if your father had a stroke, you're at increased risk for stroke. If the stroke was from hypertension, you're at increased risk for hypertension and a stroke, right? You don't stick your head in the sand. If you mother or aunt, grandmother has breast cancer, you're at increased risk for breast cancer. It's just a fact. I mean, so same thing, Cole. When should you get a colonoscopy? Age 45. When should you start getting mammograms? Age 40. Should you get them annually? African Americans, probably, yeah, they should. Colonoscopy, every 5, 7, 10 years related that. You should have your PSA. Every man African American man over 40 needs a blood test called a PSA, prostate specific antigen. And they need to know that needs to be less than 4. And that needs to be screened annually. And so we've been educating men. What is your PSA? Don't even just say your PSA is normal. What is it? It's 2, 1.7, 3.1, whatever it is. So you know what it is, because when it gets over 4, you have a much increased risk for prostate cancer, because we can't just leave this up to someone who's busy, who's typing on their computer, who's got patients in the waiting room. We got to help kind of track these things and advocate for ourselves, like patients of other communities do. They advocate for themselves. They come in, I want an MRI. It's like, you don't need an MRI. You know what I mean? But they want an MRI. I want to see an ENT for my sinus infection. I can treat a sinus infection. So my Black patients were like, can't you do my open heart surgery? No.
They can't do.
And my patients of other communities are like, whatever's wrong with me, I want to see a specialist. My back hurts, I want to see an orthopedic. So it's like they're advocating for themselves and then some. You know what I'm saying?
Yeah.
And then African Americans are like, if something's wrong with me, I don't want to know. And I'm not painting a broad stroke, but that's a lot that covers a lot of people, like my father and my brother. If something wrong with me, don't tell me. I don't want to know. Leave it alone. If I die, good. That attitude does not lead. It's true. If I die, good. But I had to convince my father. I said, well, if you have a stroke and you're sitting there drooling, what then? Now you didn't die. You had a stroke and didn't die. You had a heart attack and didn't die. Then my father started listening.
Mm-hmm.
I'm saying, but he was like, if I die, good. You know what I'm saying? but he didn't want to live maimed. He didn't want to suffer. He didn't want to go on dialysis. He didn't want to, there were things he didn't want, right? And that's what made him start to take care of himself, because just because something's wrong with you doesn't mean you're going to die from it. You may actually suffer from it. And that's what scared him. And so that was made him, in the end, as he got older, way more compliant about medicine. He changed his attitude, but I still know that attitude is out there, because people have that. Young people have that attitude, walking around with guns and all that. That's if I die, then I die. But they don't have a real sense of what that means. What if you don't die? You're in a nursing home at 27, paralyzed from the neck down due to a gunshot wound. That's heartbreaking to see.
Yes. Wow. And you've produced a vitamin called Sequence Vitamins. What's the background behind that? Why did you do that?
Well, when I was writing the book for patient-centered clinical care for African Americans, I was doing a chapter on the lab values, and I realized there were significant differences. I knew about vitamin D deficiency. 80% of African Americans are deficient in vitamin D, but I didn't know about widespread vitamin C deficiency, zinc deficiency, which they think might be related to the increased HIV incidence, increased COVID infections and whatnot. And so as I was doing it, I thought I can devise a multivitamin that would address these deficiencies in African Americans much better. And then if there wasn't a deficiency, I didn't put those in, right? And so there's no widespread vitamin K deficiency, for example. Vitamin K causes your blood to clot. And so who has the highest risk for blood clots? African Americans. Highest stroke, blood clot in the brain, stroke, blood clot in the heart attack, blood clot in the leg, DVT. And African Americans have a higher rate of blood clots. So there's no evidence that getting vitamin K causes your blood to clot more than it should, but we don't have widespread vitamin K deficiency, so there was no need to put that in there, because what if it does? And it's never really been studied. And then the vitamin E, we talked about vitamin E with increased risk for prostate cancer. African Americans have by far the highest risk, and increased risk for lung cancer, and African Americans have the second highest risk for lung cancer. So I left vitamin E, vitamin K, and selenium out, because there was some issues of whether that might cause harm. And in medicine, we try to first do no harm So sequence multivitamins have magnesium and potassium, but there were shown widespread deficiencies in magnesium and potassium. And so it's been uniquely designed for African Americans. And so when people say, this is just a Black-owned, buy sequence because it's a Black-owned, no, it's not just, it is Black-owned, but it's not just Black-owned. It's been uniquely designed. And so the Black-owned multivitamins are just Black-owned white multivitamins. You know what I'm saying?
Right.
They're giving you the same thing that there's no thought. I don't put them down and say there's no thought, but you know what I'm saying. And we should support Black businesses. And sure, yes, but if there's a vitamin that actually energy and thought was put into try to do something about these health disparities that we've talked about, why not lean into that if you can?
So the things that you've left out are things that African Americans either don't respond well to, or we all have a surplus of anyway. Is that a genetic kind of thing?
Well, it's family. I talk about the wing of my family, and maybe in everybody's family was alcoholics. Every last one was an alcoholic. If they took one drink, they were drinking for the next 3 days. No sleep. Dr. Jekyll and Mr. Hyde. That's where Dr. Jekyll and Mr. Hyde came from. These people and it's genetic, right? That everyone in that family is alcoholic, and no one can handle alcohol. They can't taste wine. You know what I'm saying? And so, in the next generation, I'm old enough now. The next generation, none of them drink because they saw the issues. Something in their family, they have some enzyme that doesn't digest alcohol properly. And so that's their family. So the African American family tends to have zinc deficiencies, tends to have magnesium deficiencies. Not all of us, and maybe not everyone in that family, although they were all alcoholics, but someone will get a gene that maybe will skip it, right? But this is just about a family. And so we know there are differences in families. The sickle cell trait runs in some families. My family has a African gene that causes premature kidney and hypertension. And so that travels in the Hall family, right? But there's things that travel in the African American family. So I emphasize that humans are 99.99% genetically the same. That's really 99.99 genetically the same. But that 0.001 part makes all the difference. That gives us our skin color, that gives us our digestion, that gives us our tendency toward obesity and diabetes. And though there are some genetic things that drive it, there's some cultural things as well. But there's lactose intolerance. African Americans are 80% lactose intolerant. So where do we get vitamin D? If we're not in the sun, we're in the city, we're inside, right? And we're not drinking milk. Where do we get our vitamin D? We don't. And that's why we're just widespread deficiency. So that was really to address that. And now I use it, which is amazing to me, that African American men have 8 times the risk of prostate cancer compared to West African men.
Oh.
So prostate cancer in African American men is not an African thing. It's an African American thing.
Yeah.
You see what I'm saying? Because for some reason we're not in Africa. We're not getting something we were getting there, getting it here. And so that's why the supplement, getting the zinc, they think zinc might prevent prostate cancer in many people. And our widespread zinc deficiency is what's causing that increased risk. They don't have that zinc deficiency in Africa because it's such a mineral-rich continent. And now we're in North America. We're not getting sun. We're not eating vegetables out of the ground. We're not getting what we need in order to avoid some of these things.
So the multivitamins that you've produced and manufactured will basically take care of these issues for African Americans. They're not for everybody. They're for African Americans.
Not even for all African Americans. There may be some that need a little bit more vitamin D or need a little bit less. Or what about when I say 80%? So 4 out of 5 have vitamin D deficiency. 1 out of 5 don't. Right? But that's still, that vitamin D will just travel right through you just like it does otherwise. But if you're taking the recommended amount of vitamin D for white Americans is 600 international units, 600 IUs. That's the daily recommended amount, right? African Americans need 2,000. That's the to maintain. If you're deficient, you're gonna need more, and then to maintain, you need 2,000 every day. So Sequence has 2,000 in it. If you just grab whatever multivitamin you have and look at it, see how much vitamin D, you'll see 600, 800, but you're not going to see 2,000. But that's what we need. White people don't need 2,000; they only need 600. You see what I'm saying? And so it is what it it's so and there's some white people that need 2,000 vitamin D, but not most of them. You see what I'm saying? There's some white people that need 15 of zinc, but not most of them. And so all we're doing is saying, what do most Black people need? Most Black people need some potassium, they need some magnesium, they need more zinc. That was the rationale I took to try to help the most people who, if you take vitamins. If you don't take a vitamin, then don't start. But if you take a vitamin, this one is better based on the research.
I see.
Is there any kind of contraindication of, for instance, if you're taking blood thinners, would this be a problem?
Well, here's the thing. There's no vitamin K. And the problem with blood thinners is that taking a vitamin that has vitamin K, and vitamin K counteracts Coumadin and warfarin blood thinners. And so you actually, if you were on blood thinners, you could take Sequence because there's no vitamin K in it.
Okay, great. Okay.
That's amazing. Thank you for bringing those vitamins available, making them available to us. It's amazing.
Well, yeah, with sequencemultivitamins.com is the website, and they're calling them genetic sequence multivitamins, and but the sequencemultivitamins.com, and they're on Amazon and on Walmart.com and more, and a lot more places to come this year.
Oh, wow.
Excellent. Well, this has been really interesting. I do have one last question.
Sure.
It's about patient-centered clinical care versus population-centered. And you may have already been kind of covering this, but can you just kind of summarize, but what is the difference between patient-centered and population-centered?
Well, the patient-centered is something that cross medicine, not just in African American, cross medicine. We're trying to give care that a patient needs. And so, so if, let's say you don't smoke, we don't need to spend 10 minutes talking about the fact that you need to stop smoking because you don't smoke, right? So, but if I give, everyone a population-centered care, then a lot of people smoke, then I would make you have to sit through that, right? And so, so it's centered like, what do you need? Do you need more time with me talking? Do you need more trust building? You need, what is in your family? What is your genetic history, in terms of risks, those things in terms of what you need. Versus when they gave a population for African Americans, they say, well, African Americans are poor. They tend not to have good insurance. So I'm not going to refer them to physical therapy because their insurance is not going to cover. I'm not going to refer them to cardiologist. The cardiologist is probably not going to get paid, or, what I mean? So then I'm going to do this second plan because I'm grouping all African Americans, but and 90%, in Cuyahoga County we have a 10% poverty rate for African Americans, right? So that means 90% aren't poor, right? 90% have insurance and are working, right? So that's a misnomer that that if you treat all African Americans as if they were poor, then you're going to get poor outcomes. We are disproportionately higher on Medicaid, right? But still, there's way more white people on Medicaid than Black people. But there's just more, I think it's 32% in Ohio. There's 16% of African Americans, but there's 32% on Medicaid. So that's way higher, right? Compared to the 4% of doctors, right? But there's still another 70% on Medicaid that aren't Black. You see what I'm saying? And that a lot of times that gets lost. And what kind of care do they get? They get care based on their population. Their population tends to be insured. Their population can get referrals. Their population will cover this medication, this latest medication. So it's that those bias and sort of quick decisions can make a difference in the end. So patient-centered is like, what do you need? And so every room is more work on providers, but it's worth it. I think it's worth the extra energy because you get better outcomes.
I see. Wow.
Amazing.
Big difference. I would think that isn't how medicine always should have been, that it's patient-centered.
Things change, right? I was looking in the living room, looking at the telephone jack, on the wall. And I'm like, I got to spackle that in. You know, I don't need a telephone jack, right? We used to have a
Right.
telephone in all the rooms, and we don't. My kids will be telling their kids, "Remember when we had a telephone on the wall in the kitchen?" You know, and things change. You know, and so now everyone's walking around with telephones. Everyone's walking around with computers. You know, and everyone's more. A lot of people are more educated, and we also have more access to false information, right? And a tendency for conspiracy theories and all this stuff. And so it's we're just in a different place.
Okay, that is true. So much has changed,
Mhm.
happening fast. Well, I have finished my espresso, and I even had a double because there was so much to cover.
No
I had
problem.
a double mint tea.
Well, I'm waiting. In about 6 hours, I'm gonna have a double of something else.
Sounds
Yeah, in
good.
about 6 hours, I'm doing a double too.
Wonderful.
All right.
Thank you so much, Dr. Hall. I mean, it's been just fantastic, and I've learned so much, and I think my trust meter went up a little bit too.
Good, good. I appreciate it. Well, I appreciate you all real easy to talk to. I really appreciate it. I really appreciate you having me on.
Thank you so much. It's been amazing.
Oh, thank you.
Well, and I hope that maybe we can talk again sometime soon.
Absolutely. I'm happy to come back whenever you want.
That would be great.
Thank you so much again. A big asante sana. And well, I'll go get our doubles, huh?
Absolutely.
Soon.
Thanks.
Thank you.
Thank you very much. Okay, bye
Bye-bye.
for now.
Bye.
This ends today's discussion with Dr. Gregory Hall. Alafia Espresso Talk Today community, it's Amma Robin again. Wow. Really? Wow. And I know you know what I'm talking about. This was an amazing discussion, wasn't it? Yes, it was. And there was so much more that we could have talked about, but we do have a lot to get us started. First, I want to say another big Asante Sana thank you to Dr. Gregory Hall for his work to support and improve Black health. Dr. Hall's commitment and work as a physician and scientist and author are definitely making a difference in the Black community. He's helping us to live healthier lives. It's a real commitment. This conversation could have been called a Black empowerment conversation because Black health is Black empowerment. I keep repeating that, but it is so true. Dr. Hall discussed the data on Black health disparities and gave us information that can empower us towards optimum health. And health is power. Well, we're going to get to some of the data in a minute. But first, there's one thing in particular that caught my attention. There was a whole lot, but this one in particular just resonated with me. Dr. Hall discussed that the disparities in healthcare are, in the words of Dr. Martin Luther King, both shocking and inhumane. He also noted that the medical community bears some responsibility for the health disparities and the health problems experienced by Black people. I would call it blame. He mentioned medical bias and race driven treatment that make us as Black people less healthy, less likely to receive the treatment that we need to improve our health outcomes. He discussed that doctors and nurses are not just detached observers, but that they're active participants in this racially biased system. That is really powerful to hear, especially from a doctor. But he also noted, and this is the part that really resonated with me too, that there are things that we as Black people can do to improve our health. The Black community suffers from something that he called health illiteracy. That's the first time I've ever heard that term, health illiteracy. He said that this is not only this experienced by the poor people, poorest people with less education, but by Black people across the socioeconomic spectrum. Really, it shouldn't be allowed by anybody. It shouldn't be experienced by anybody. But we can't say that, well, it's about poverty, because it isn't just about that. Remember, he talked about this in the context of Black folks drinking sugary sweet drinks rather than just water with perhaps a sprig of lemon, and how this can and does cause obesity and diabetes. These are something that are experienced in the Black community. We just have to admit it. Here's the empowering part for me. Dr. Hall said that we can do things that directly improve our health. Getting health literate, for one thing. We can exercise, take walks. We can focus on those areas where we do have control, and then we can take control. Drink water. Put away the Coke. You remember last week, Dr. Yancey also gave us those 8 essential steps that can help us towards optimum health. I really would love to point total blame at the American healthcare system for the problems of Black health. And of course, they do have a lot of responsibility, lots of it. But that approach would also disempower me, and I'm not into disempowerment. Dr. Hall emphasized that we all have a part to play in this shocking disparities. We all need to be willing to see what we can do better, and getting health literate is one big step towards getting a better health outcome. Back to the data. We did have a lot of data on this show. Remember, he's a scientist and a researcher, so I love that he's data driven. Here's one piece of data I really found interesting. 45% of Black people do not trust the healthcare system. Remember on the show, I said I'm one of them. There are reasons for this distrust. Many are valid, but distrust also negatively affects patient health outcomes. There's a reason for the distrust, and there is some validity to that, but I don't want to do anything that's going to make my health outcome, that's going to diminish that. More data. Black people have better health outcomes when we have a Black doctor. Black people have better health outcomes when we have a Black doctor. The problem, only 4% of doctors are African American, are Black. There are not enough Black doctors to treat the numbers of Black patients. Black people make up, 13 or 14% of the population. And so there aren't enough Black doctors across all the specialties. Most Black doctors focus on primary care. As I said, it's everyone's favorite doctor. They're the first step out, through the gate, and that's really important. But the data is clear. For Black health to improve, we need more Black doctors across all specialties. This is one reason that Dr. Hall founded the National Institute for African American Health, to mentor more Black doctors, to train more Black doctors, to increase the number of Black doctors. There really is so much more we can talk about, but we do need to close this uncommon but really important conversation. And we're going to continue it later. We're going to keep talking about it. Black health, or health in general, is not a single solitary discussion. It's an everyday, all-year discussion, and it's a goal for the whole year. Black health, I'm going to say it again, is Black empowerment. The final thing I want to point out is the difference between patient-centered care and population-centered care. Patient-centered care focuses on giving the individual patient what they need. It is tailored and it's focused. It responds directly to the patient. Population-focused care focuses on the needs of the broader population. This care is general and broad. It does not respond to the specific needs of that patient. Rather, it responds to the general needs found in the population. Just a question. What kind of care would you prefer? Honestly, I want a doctor who is focused on my specific needs as a patient, not an algorithm or a white Western-dominated approach. Patient-centered care is really the gold standard of care in the American healthcare system, which is mostly white and insured. And it was not designed to respond to the needs of Black people with different culture and histories and diets and even different insurance coverage. Dr. Hall notes that patient-centered care is really demanding, but it's worth the extra effort because the data shows that you get a better outcome. And that's what we all want, isn't it? A better outcome. For everyone. Not for some, but for everyone. Again, I want to say a big asante sana to Dr. Gregory Hall for sharing his valuable time with us to discuss health disparities and to tell us what we as Black people can do to live healthier lives. And I say asante sana to Mel and to you, my community, for being in the building with me today. We're so grateful for your support, and you really are the reason that we do what we do every single day. Remember that Dr. Hall said that we all have a role to play in improving our health. Health literacy is so important. Know your cholesterol numbers, know your blood pressure, know your glucose or A1C numbers. Learn about diet and exercise. We all can do better, and we can live healthier, happier, and longer lives. I'm going to say it again. I don't know if even if you're tired of it, I'm going to say it again. Black health is Black empowerment, and we hope that you're feeling the empowerment and sharing it. We are a community, and we can work together. So this ends our show with Dr. Gregory Hall. If you have any questions, please feel free to contact me at team@espressotalktoday.com or on Instagram at AmaRobinL. That's the letter L. I also encourage you to check out Dr. Hall's sequence vitamins. He's also written the book, Patient-Centered Care for African Americans. This really is a great book that can empower you to be more health literate and to know what you need from your doctor to be healthier and to have a better health outcome. You can also listen to Dr. Hall's podcast show called Better Black Health. I love that name, where he discusses everything from the issues of the tattoos to the importance of walking every day. You can find links to all of this information on the Espresso Talk Today website, espressotalktoday.com, or on our Habari page. Now, Habari means information, so on our Habari page on the website. And you can find this information on my Instagram page at AmaRobinL. There's a lot of information on both the website and the Instagram page, and we want you to have all this information, so we want to make it easy for you. I'm Ama Robin for the Espresso Talk Today podcast show, and remember, now more than ever, strength, soul, and reparations. Ashe.